hear me okay? Good, all right. Let's get started then. Let's talk about some of these things. We're going to understand a little bit of COVID-19 as sort of a jumping off ground, and I think it's a great way of talking about the human body because it's something that relates to everybody. And I know that everyone, well, not everybody, we're in this feeling right now that COVID's done, it's over with, and we can finally come out of it. Unfortunately, if you look at the data today in the last couple of days in Europe, counts are going back up again. So you can take a look, and we are going into a period of time here where it's not just one crisis or another, it could be multiple crises at the same time. So we need to understand the data on natural remedies and why they may work, and understand the history of natural remedies and understand where we are. Which is kind of an interesting place for me as a critical care physician, because if there's something that I am used to, it's something that I've cut my teeth on, something that I have done for many years. I've practiced as a critical care physician. There's nothing in my realm that relies on natural remedies. Somebody comes in with septic shock. Think about where this patient is. This patient is generally older. If it's a male and they're here for a urinary tract infection, it's because their prostate has been enlarged and they're not urinating, and they've developed a urinary tract infection, and unfortunately no one has figured this out. Maybe he's from a nursing home and he's now coming in with a blood pressure of 60/40. His sodium level is 155. He's altered, he's confused, and he's what we call instant man. Dr. Enrique Gill, one of my colleagues, we call them he's Hispanic. He say, Roger, he's instant man. Just add water. And that's literally what you do. You just fill them with normal saline and they get better. But to get to that point, you have to start vasopressors. You have to put a central line in. You have to, and this is the training that I've had. There's nothing natural about anything that we do there. I mean, it's a natural substance of the adrenal gland, but we give it in such super doses. And so one of the things that we'll talk about, especially tomorrow when we talk about this, is understanding that to embrace natural remedies does not require you to release things that you know also work. Okay, this is the problem, and we'll talk about this. There is a false dichotomy, and this false dichotomy that's been set up, and we'll talk more about this. This is really instrumental in what we're going to talk about. Is there's nothing that Satan would love more as for the people on the pathway to Jesus to be arguing from the left and the right, pushing each other over on each side and falling off the pathway. That's what Satan wants to have happen. Okay? So I am working, and I'll just sort of give you a little precursor to this, is I post a lot of things on my MedCram channel that, let's just say, I might post something about modern medicine. And maybe here's a study about modern medicine, right? And who makes stuff today in the realm of modern medicine? Pharmaceutical companies, okay? And then I might post something on my channel about light or water or healing. And I will get hate mail in both cases. I will get hate mail saying, how much are you being paid by the pharmaceutical companies? How much are you being paid? And then I'll get hate mail from the other side that says, it's irresponsible of you to be talking about these things when we know that the vaccines work. Do you see what has happened? Do you see what Satan has done to us? All right? So we have to cast that off. Here's the vocabulary word for you to learn before now and tomorrow when we talk about this. Syncretism. Syncretism. How many of you know what that word means, syncretism? Yes. Okay? A lot of the problems that we have in this world has to do with syncretism. Look it up, and we'll talk about it tomorrow. So this is the world that I came from. What you're looking at here. This many milligrams of this, call the pharmacist, do this. And for me, what was the charging impetus was COVID-19. Because here we had a situation where we knew how to deal with people who were sick in general, but what was it specific about COVID-19? I think it's a great jumping off point. More pictures. It's just crazy stuff. I mean, I couldn't, unless you're a critical care physician working in the hospital when all HE double hockey sticks are breaking loose, and you have two codes running at the same time. The words can't be described. And when people are dying and the family members can't be there, it's literally like a war zone. Yeah. So we found out very early on that the course of disease of COVID-19 goes like this. There is a period of time before you get infection. There's an opportunity where you can work and try to reduce it. And then after infection, there's about a 5-day period of time where you have no symptoms or you're pre-symptomatic, and then you start to develop symptoms. That's known as the incubation period. Then this goes on for about 7 days. So for 7 days, your innate immune system, which we'll talk about, is trying to battle this virus in a very different way than how the adaptive immune system is going to battle the virus. You have two branches of your immune system. Think about them as the Navy and the Air Force. They both battle the enemy. They do it in very different ways. The innate immune system is very robust when you're young and gets weaker as you get older. The adaptive immune system, things that use antibodies and proteins, is learning when you are young, but gets very sophisticated as you get older because you've been exposed to a lot of different types of diseases. The way I like to mention this is imagine you've got a babysitter and you've got some very bad kids, and the kids are running wild around the house. The babysitter's like the innate immune system in this situation. Hey kids, come on, come here to the living room, let's sit down. No, don't write on the walls, no. The adaptive immune system is like the parents coming home, okay? What is happening here? Johnny, come here. That's the adaptive immune system, and that's when the antibodies come in, and there's a huge inflammatory reaction, and that's what gets the patient to the hospital. Because the virus has been able to reproduce so much in the lungs that now the adaptive immune system is attacking all of that. And instead of having a paper-thin membrane that you can diffuse oxygen through, it's now become inflamed, it's become thickened. That tennis court-sized lung surface area that you once had is now a thickened glob, and you can't oxygenate. And that's what happens at the end of day 7. From there, things rapidly deteriorate. People get intubated, they go into ARDS, ICU, and then die. Okay? And obviously, as we progress, the population of people that progress gets smaller and smaller and smaller and smaller. And eventually, you've got about a 1% of the people who actually die from this condition. But let's not forget that about 10 to 15% of people will have to be hospitalized. Okay? And that's the issue. And so I want you to keep that in mind. So the course of the disease is you have a population that get infected. About 80% of the population gets better, about 20%, 15%, 10%, depending on what kind of things you have in place, will get sicker, and they will need to go to the hospital, hospitalization, need ICU ventilator treatment, and then even on to death. That's kind of how it goes. So if we can improve the immune system, if we can improve the 80% to, let's say, 85% or 90% or 95%, we can do a lot, not only in saving lives, but also taking the stress off of that last arrow, which is hospitalization. Because that is where the real problem is. Let me just tell you kind of what my experience has been. So we have about 900,000 acute care beds in the United States. Okay? We have 300 million people. If 10% of the people become sick and need to go to the hospital, that's 30 million people. We only have 900,000 acute care beds. Do you see a problem? So you have to really understand, when people say, why are we worried about a virus that only has a 1% mortality? That's a view from one person. Do you understand what I'm saying? That's not a whole view issue. You've got to look at the whole picture. How are we going to take care of this many patients when our healthcare delivery system can only accept these many patients? And it's not like hospitals build hospitals with 20 beds being unused. Do you understand what I'm saying? So this is the issue that you have to deal with when you're talking about population issues. And so with this last round of Omicron, for instance, you know what the big issue that I saw? We did see our cadre of patients that need to be intubated, but do you know what the real issue was? I'm getting a peek into what last day events are going to be like. A lot of patients that were coming in because they couldn't get dialysis. I saw potassiums of 8.8. And when we would normally call for dialysis, we usually have dialysis there within an hour or two because that's a very significant problem. They couldn't come until the next morning. So we were doing these, the potassium cocktails that you normally think about, the low calma or the Kxalate, the sodium bicarbonate, the insulin and the glucose. We were doing that repeatedly throughout the night, trying to keep this patient under wraps till we could get finally dialysis. Why was that? It's because Omicron was spreading so rapidly that they didn't have enough dialysis nurses. People were missing dialysis over and over and over and over again. That was one issue right there. So when the infrastructure falls, there's going to be a bunch of people that are not going to have dialysis. So just be prepared for that. Just understand that that's the case. When you don't have supply, there's a bunch of your type 1 diabetics, they're not going to get insulin. So there's going to be a huge amount of DKA that's coming into the hospital, or they're just going to die. Okay, so our supply chain, you have to understand that our supply chain is so fragile that a lot of people who are out there that are not in the medical field, they don't understand this. And so when people tell them that this is a conspiracy, that this is 1% of the population is going to die, things can unravel very quickly. We had patients that, you have a heart attack at your home, the ambulance take you to the nearest hospital. Well, that hospital doesn't necessarily have an angiocath, right? An angiolab. So they have to be transferred to a tertiary care center. You can't transfer people to tertiary care centers if that hospital is inundated. There's no beds. There was one gentleman, they looked 46 hospitals to try to transfer them to. They could not transfer him. He died at that hospital. And this is a story that's happening over and over and over. I don't have to tell you this. So the key here is that if we as Adventists who understand this, someone mentioned it today, the only line of ministerial work at the end is going to be medical ministerial work. We are not going to have a supply chain. We're not going to have hospitals. We're not going to have the things that we're used to having. And so having a knowledge about how to do this is going to open up ways like you would not believe. I have a personal testimony to tell you tomorrow. You're not going to believe it. It's good. It's very powerful. So be prepared. So this 80%, 20% is where we need to focus our attention. Early versus late. Okay, so here's the cells of the immune system. The innate immune system's on the left. The adaptive immune system is on the right. Notice the components of the innate immune system. We're talking about monocytes, eosinophils, neutrophils. These are very generalized types of cells, whereas we have the T cells, the antibodies, they're on the right. That's the adaptive immune system. Those are the parents that come home, right? One of the major products that we're going to talk about is interferon. Interferon is a great name for a cytokine because it interferes with infection, and it's the main product of the innate immune system. We'll talk more about that. Why is that important in COVID-19? Very good research published in Science, which is a very prestigious medical journal that shows that patients who mount low interferon responses get very high likelihood of severe COVID-19. They showed this very elegantly in a number of studies that looking not only at interferon alpha-2, but also interferon activity. Interferon is the major product of the innate immune system. If your innate immune system is very powerful, it is very strong, the chances of you progressing to COVID-19, and I would say, by the way, any other virus you want to put in there, the flu, next year's pandemic, 10 years from now pandemic, it's all going to be the same. You need to be able to mount a strong interferon response. So the take-home points, SARS-CoV-2 encodes many proteins. It's actually been shown, by the way, that SARS-CoV-2 proteins in the nucleocapsid actually actively suppress the body's ability to make interferon. There's some immunologists that will tell you this, that your immune system is so well designed that a regular viral infection, it should take care of 100% of the time. The only reason why you get sick is because the viral proteins in some way, somehow are designed to knock out your normal, regular immune system capability. Okay? So this is what happens when you don't have a good innate immune system. The virus replicates, it gets into the cells of the lung, and then the adaptive immune system comes on, and it starts kicking butt. Okay? The parents coming home and figuring out what's happening. And that's not good because then you cannot transport oxygen into the lungs. So COVID-19 management, I would say, is divided into an early and a late phase. Much better to get it done early than to wait for the patient to have to get to the hospital. So, as we'll talk about tomorrow, there are a lot of criticisms on the right that are correct about the left. And there are a lot of criticisms on the left that are correct about the right. And it's because we've drawn the line in the wrong place. Now, we'll talk about synchronicity, or whatever I said before, right? Right, okay. One of the criticisms is that we didn't concentrate on early therapy. And there's a good reason for that. The reason why we didn't concentrate on early therapy early on is because our entire healthcare industry is based on chronic disease. Chronic disease doesn't need to rush. We can take our time, we can do randomized placebo-controlled trials, and because of the history of this country where we sold snake oil in the 1800s, we need to make sure that, first of all, it's safe, it's efficacious, and that it works. And that's the system that we have in place. Our system is not designed for rapid assessment of possible therapies and implementation. It's not designed for that. It's absolutely not designed for that. The way we manufacture medications, the fact that we make medications, is not designed for rapid implementation. And we'll talk a little bit more about why that's the case at the end of this talk. So we didn't do early treatment, and that's the problem. We waited for the patients to get sick in the hospital. I know patients call their doctors. They said, "What do I do?" They said, "I'm not a COVID doctor." That was the response. We waited till they got into the hospital to treat them, and then we treated them with medications like remdesivir, which doesn't work very well when it's given late. But we had no choice because remdesivir is an intravenous medication, and it's very hard to give it as an outpatient. Right? Do you understand where we are? But on the other hand, the right also accused the left of saying, you know what, you guys will never come up with a medication that's cheap and effective because the pharmaceutical companies don't want it, and you've bribed the FDA. But you know what? You know what the cornerstone of treatment is of patients in the hospital? It's dexamethasone. Dexamethasone is dirt cheap. It ran out of its patent a long time ago, and it's been shown to actually reduce mortality. And the UK recovery trial did the study very early, and we've gotten the results and we're using it. So, you'll find out, this thing has become so politicized from the left to the right that the truth has been lost. And so actually, remdesivir, used convalescent plasma, dexamethasone particularly has been shown to be very well tolerated. But why wait till it's late? Let's see if we can treat them early. And I think that's the key of what we're talking about, which is natural remedies. So the problem is that there's too many people. So even if we were to find a miracle drug, how are we going to make it fast enough for everybody? Remember what happened when hydroxychloroquine was thought to be beneficial? I had patients on Plaquenil. They couldn't get it. Can't do it. There's no way you can make enough medicine to treat hundreds of millions of people. And so that's the problem. So we have remdesivir, dexamethasone plasma toward the latter part. We've got non-pharmacological solutions early on. What's the key for non-pharmacological solutions? Here are the key. Here are the key points. The characteristic of an early phase intervention is something that is safe with little risk. It's something that is effective. It's something that's able to be implemented without having a test result. It has to be readily available so that there's no rushing or hoarding of it. And it works with currently acceptable treatment options, so it doesn't interfere. And it has to be easily teachable. Because if millions of people are going to come down with this problem, you cannot be depending on just the physicians to be meting this out. This has to be something that the physicians, the ministers, does this sound familiar to you? And the lay people have to learn and then teach it. This is the key, okay? So the key for early intervention phase has to have all of these things. And guess what? We have a number of them. Not all of them have randomized placebo-controlled trials, but I'll talk to you a little bit. We need to do that, by the way. We need to do randomized placebo-controlled trials with these sort of things. But we shouldn't wait for those to be done before learning these ourselves, because we have something a little bit more than just science. We have prophecy. Correct? Okay. So what are some immunity-enhancing interventions that might take the 80% up? Vitamin D. We'll talk about natural substances, sleep, hydrothermal therapy, or just hydrotherapy, diet, and exercise. Let's go through these quickly because there's a lot of science. Vitamin D. We know that vitamin D is not just a vitamin, it's a hormone. It's made in the skin, ultraviolet B radiation. It gets metabolized in the liver, then goes to the kidney. and it does its nice work. We have a lot of data on bone metabolism, and we're supposed to be taking 400 international units a day, according to bone metabolism. But just because you need so much flour to make this recipe, it doesn't mean you need this same amount of flour to make this recipe, right? Maybe the amount of vitamin D you need for bone health is different from the amount of vitamin D that you need for good immune health. But our leaders are just very focused that this is all you need, and therefore that's all you need. I'll show you some data. We know conclusively that vitamin D levels are associated with, high vitamin D levels are associated with better outcomes, and low vitamin D levels are associated with worse outcomes. This is over 190,000 people, and basically looking at the SARS-CoV-2 rate and the vitamin D levels. Okay, you can see clearly that as you drop below 50 nanograms per milliliter, that the rate of SARS-CoV-2 goes up. And it doesn't matter what portion of the country you're living in, it doesn't matter how old you are, it doesn't matter what race you are, it doesn't even matter what gender you are. It's the same effect every time. That's pretty powerful. What about mortality rate? Same sort of thing, except we're looking at high vitamin D countries and low vitamin D countries, and what the mortality rates were in Europe. Same effect. Again, association doesn't necessarily mean causation, but there's a big association here. What about observational studies with vitamin D? This is calcifediol. So the problem with vitamin D is that it takes a long time to get up to a steady state. It has to be metabolized. And so if you're starting it when someone is already sick with COVID, it's probably not going to work, right? Well, there's been some trials where they actually take already metabolizable vitamin D. That's called calcifediol. It's only available as a prescription. And they gave it to those patients, and this was over in Spain, and they actually showed that there was an improvement when they did this. There was a statistically significant improvement in this randomized pilot trial. I don't know where this has gone, but the point is that imagine how much better you would be if you had regular vitamin D levels before you got COVID. This was another study that was published, again, randomized, not blinded. It was open label. This time 900. 500 got calcifediol, 300 got control, and what they found that there was a mortality rate reduction from 15% down to 6.5%. That's a number needed to treat of 12. That's pretty good. Okay, the lower the number, the better. And that was an absolute risk reduction of 8.5%. How about this trial? So now not talking about COVID, let's talk about autoimmune disease in general. Here they took 12,000 in each arm, control versus vitamin D. They put them on 2,000 international units, and they followed them for 5 years. And there was a statistically significant reduction in all autoimmune conditions, period. Ulcerative colitis, Crohn's disease, scleroderma, you name it. They looked at all of it. Prospective study, 2,000 international units. That's well above the recommended. This just got published about a month or two ago.
That was daily
2,000 international units. Okay, that's vitamin D. Remember what I said in the first talk. It would be a mistake to assume that because you're on a vitamin D supplement, you don't need to go out into the sun. That would be a mistake. But it wouldn't be a mistake to supplement. All right, what about natural substances? Essential oils, right? Have you guys heard of essential oils? Yeah, I think you have. I know it's a controversy, right? What about essential oils? Well, here's a group of researchers that were getting tired of their chemotherapy patients getting sick when their immune systems dropped. And so what they decided to do was they looked at the in vitro effect of eucalyptus essential oil. What major product on the market has a lot of eucalyptus oil in it? Vicks. Do you know that during the Spanish flu of 1918 and 1919, almost they had to sort of watch it very carefully. Almost all of the eucalyptus trees in Australia were cut down as a result of the worldwide demand for eucalyptus oil at that time. Why? Because they know that this works. Do you remember a health reformer from the 1800s talking about putting a drop of eucalyptus oil in some honey and drinking it and taking care of her cough? I kind of remember that. Well, I think this is kind of an interesting study because what they did here if you look at this 12 pictures of the electron micrograph, you've got the control group in the first column. You've got what they look like after they're given LPS. That's lipopolysaccharide. That's kind of like a stimulant to tell the immune system you've got an infection going there. And then in the final column, what happened when instead of giving them LPS, they gave them eucalyptus oil. What do you notice there? Let's look at the bottom one. You see that thing that looks like a fried egg? Yeah, the bottom right, bottom left-hand corner, J. It looks like a fried egg. It's just kind of sitting there. That's a white blood cell just kind of sitting there on an electron micrograph. You give it LPS. Do you see all those little tentacles there in the middle picture at the bottom? That's all just sort of coming out. That means it's ready to do business, okay? Now, what do you see on the eucalyptus column at the bottom? Very similar. So eucalyptus oil tells your immune system, hey, there's something out there, start looking for it. Same thing here on the right panel. What you're seeing here is red nuclei surrounding with little yellow beads. The little yellow beads are simulating foreign particles. And what you see here as we go from top to bottom, control on the top, LPS on the middle, and then eucalyptus at the bottom. What you're seeing there is that all those little yellow particles are being phagocytized inside the cytoplasm. And so what's happened is eucalyptus oil has stimulated these white cells to eat up these antigens. So what did they say? They said, overall, our data demonstrating that eucalyptus essential oil from Eucalyptus globulus is able to implement the what? Innate cell-mediated immune response. What was the effect that we saw in COVID-19 that was reduced? The innate, exactly the same part of the immune system. Isn't that interesting? So eucalyptus oil may improve innate immunogenicity. I would not ingest it. I would use it externally because there have been reported deaths when you actually take too much eucalyptus essential oil. It can be toxic. It's extremely powerful stuff. All right, does that look nice? Are you feeling the infrared radiation coming off the trees? By the way, have you ever noticed when you go on your Sabbath afternoon walks that if you come to a forest, it's hot, and as soon as you go under the canopy, what happens to the temperature? It cools up. Guess why? That near-infrared radiation is being reflected. Those leaves and those, it does a very good job at reflecting near-infrared radiation out. So this was a really interesting article. The Japanese love this thing called forest bathing. And what did they find? They took 12 healthy men, and they say, oh, it's only 12. But they were able to find an effect with just 12. What does that tell you about the size of the effect? It's pretty large, right? So these are Tokyo executives. Think about these guys working and living all day inside of a building, working at a large company. And over a series of days, they took blood, and then they took them up to the forest in Japan and took blood samples in the evening and in the morning. They had them do a 2.5 kilometer hike for a couple of hours. They slept overnight, then they went back home again and took some more blood. Okay? That's all they did. What do you think happened? Well, they looked at a bunch of things, like natural killer cells. And they noticed that there was a statistically significant increase in natural killer cell activity in those patients that went, in those subjects that went up into the forest. They also looked at the size of the granules in these cells, like granulysin, perforin, granulenzyme A, and granzyme B. And all of them were statistically significantly higher when they went up to the forest. And this was a particular forest that had something called Hinoki cypress trees. Hinoki cypress oil is what they were looking at. They also took air samples, and they found that the air samples had high concentrations of Hinoki cypress phytosides in the concentrations. And it's interesting to me because we always like to get our Sabbath afternoon hike every week. Guess how long the effect lasted? 7 days. 7 days. It was fascinating. By the way, they repeated the experiment, except instead of them taking them up to the forest, they put them in a hotel in downtown Tokyo, and they put a diffuser in the room, and they diffused Hinoki cypress oil. And they found very similar results, except for one aspect of it. When they went to the forest, they also checked urinary cortisol levels. And those urinary cortisol levels were low. They were relaxed, not stressed. There's something about the forest that gives them that relaxed state. When they did the same thing in the hotel room, they had the same kind of things here with the granzyme A and perforin, but their urinary cortisol was not reduced. Okay, so I think that was fascinating for me. All right, let's talk about sleep. So here's a truism I think that's really important. Again, the false dichotomy. Get the vaccine or do all of these natural remedies to boost your natural immune system. Here's the reality. Vaccines work much better on immune systems that are fortified rather than immune systems that are not fortified. Here's the proof. 25 people randomized to sleep versus sleep deprivation, and then they're given the flu shot. Notice the antibody titer. They found that the antibody titers in those that had a full night's sleep had almost more than twice the antibody titer than those that were sleep deprived. Okay, so if you want the true benefit of a vaccine, it's better to have an immune system. This goes along with the truism of the vaccines work through the immune system. Okay, if you don't have a good immune system, it's not going to work as well. I also saw this in my critical care unit. Who were the patients that were coming in that were vaccinated? There were very few, but the ones that were coming in were elderly. They had autoimmune conditions, even though they were vaccinated. So what does that tell you? They weren't working very well. They didn't have a good substrate to work off in the first place. So if your immune system is not working well, it's not going to be working well in any kind of situation anyway. Proof again. Here's another one. 153 subjects, sleep quality and quantity, prospective trial. What they did was they did a questionnaire to see how well they were sleeping. And then they actually, and this is college students, right? This is what they do. They go for these things and they get paid. They actually took droppers of rhinovirus and dropped it into their nose. How many want to do that? No, okay. What they found was that those people that were getting 7 hours of sleep at least versus 8.5 hours, there was a 2.9 times higher rate of infection in those that were not getting enough sleep versus those that were getting enough sleep. 2.3-fold just based on sleep. This kind of goes along with what excuse me, what we were talking about before, which is it's multiple areas. 2 millimeters of mercury difference in blood pressure in one place, another 2 in another place. This is just sleep. And we're talking about a 3-fold drop in rhinovirus. Dr. DeRose, right? Exactly. All right, so quality of sleep. What about quality of sleep? That was 5.5-fold. So if you're not getting good quality sleep, your immune system is going to suffer. So they say here, because of the prospective design and the controls for multiple confounding factors, these results strongly suggest the possibility of sleep playing a causal role in cold susceptibility. You guys know this already though, right? If you don't get a good sleep, you're going to feel worn down. That's when you get sick, right? You travel a far distance on a plane to a different time zone, and your sleep gets off. What happens? You get a cold, right? And you say, I must have got it on the plane, right? Maybe, maybe not. All right, hydrothermal therapy. This is going to be quite interesting here because we're talking about the innate immune system. And remember what we said about the innate immune system? The major output of the innate immune system is interferon, because it's a great thing. It causes interference. And we talked about the fact that interferon, if you have a good response of interferon, your chances of going on to severe COVID are less. So we would all love to have great innate systems that can give us a lot of interferon. Here's another study that was confirming that. In patients that had genetic abnormalities in the genes that were responsible for producing interferon, all of those patients had severe COVID-19. You can see it. Those are the green dots on the screen there. This is the amount of interferon that they were producing. All of these patients had severe COVID-19. And then those that had antibodies against interferon, those are the ones there in blue, even though they were making interferon, they had antibodies against it. All of those patients as well had severe COVID-19. In fact, the scientists that looked at these two papers that were published simultaneously in Science, they said, quote, together these two papers explain nearly 14% of all severe COVID-19 cases. Just these two mechanisms. That is quite amazing, she says, an immunologist from the Karolinska Institute. Is it interesting? Is it interesting? Okay. Well, let me take you back. Let me take you back to a time period back in the late 1800s where there was an Austrian psychiatrist who noted in his patients in his insane asylum in Austria that those that had neurosyphilis seemed to do a little bit better when they had a fever. Fever is the major output as well of the innate immune system along with interferon. In fact, fever will stimulate interferon to be produced. So he had this idea. He said, what would happen if I took a patient with malaria and drew the blood off of that patient and then injected the malaria into my neurosyphilis patient and see what happened? Well, they actually had the treatment for malaria at the time. It was done very carefully. The patient with neurosyphilis developed very high fevers very frequently, and guess what happened to his neurosyphilis? Got cured. And then he treated the patient afterwards with quinine, and his malaria went away. For this work, Dr. Julius Wagner-Jauregg received the Nobel Prize in Medicine in 1927. Notice what it says. In the following years of his discovery, artificial fever was induced by any one of the following methods: the introduction into the patient of a parasitic disease, the injection of a foreign protein, injection of chemical substances such as sulfur, electrical means such as the administration of diathermy or radiotherapy, or placing the patient in an electric field. Notice the next part. And simple immersion of the individual in a hot bath or placing him in a heat cabinet. Wagner-Jauregg's therapy was highly admired and was used on neurosyphilis cases well into the 1950s. However, with the introduction of penicillin, ironically the very next year in 1928, syphilis treatment, fever therapy effectively ended. I'll tell you, it didn't effectively end just for that. If you look at the old photographs of the sanitariums, you'll see a hallway with little holes down the wall where the heads would stick out, and the bodies would be inside the room getting heated up with hydrotherapy. But it was very labor intensive. It was much cheaper and much more effective, they felt, to give penicillin to these patients. It did it just as well. And you didn't have to have the labor. That reduced costs. And so in 1928, we essentially ditched an entire spectrum of types of therapy that we felt was effective for something that was cheaper. And if you look at the 30,000-foot view of what we've done in the last 100 years, we are where we are because of what we've done. Every system is perfectly designed to get the results that it gets. The question is have we lost something? Have we lost a potential way of treating things? I'm not saying we throw away these treatments that we now have that can take care of people like the elderly gentleman who comes in with septic shock. I'm not aware of any natural remedies that will take care of a patient with a blood pressure of 60/40. Okay? But have we eliminated a potential modality of treatment that can be used, as we talked about, in those ways, easily accessible, don't need a diagnostic test, widely available, easily teachable, and expanded to many, many people so it can be used in a time of crisis? Have we eliminated that unnecessarily? I would say so. Here's the proof. Well, here's the proof for action. Here's a study that was published looking at hypothermia in humans that enhance what? Interferon synthesis. So what they did was really interesting. They took lymphocytes out of the human body at different temperatures. At 37 degrees Celsius, at 37.5, at 38. By the way, 38 is the definition of a fever, which is 100.4. 38.5, and then finally at 39. At 39 degrees Celsius, there was a 10-fold increase in interferon at that level. So that's what we did. And here's the experience of that. So this was not in a vacuum, right? We have John Harvey Kellogg, we have the Battle Creek Sanitarium, we have patients there. This was all going on. Have you seen the book that John Harvey Kellogg published? It's about 1,000 pages. It's available on the internet. You can get it for free and read it if you'd like. And it's all on hydrotherapy. I think we've heard of John Harvey Kellogg, but really, and the publication quality that this guy did, he was a genius. There's no other way to describe what he did. And what they talked about was sanitarium rational treatment, what it involved: rest, fresh air, sleep, peace, hydrotherapy, sunlight. That's what they did. And here are the sanitariums that did it. Notice, not a lot of buildings. fresh air, open space, trees, grass. Here's the Loma Linda Sanitarium. You can't even see it because it's in the trees, right? So there was this doctor called Dr. Wells Rubel. Are you familiar with Dr. Rubel? Dr. Rubel was the medical director at the New England Sanitarium in around Boston. And he said in his publication on May 1st, 1919, in the periodical Life and Health, in an article titled As We See It on page 115, you can look this up, he says, the present epidemic of influenza has furnished excellent opportunity to test out the efficacy of rational treatment in dealing with respiratory disorders, especially in conditions accompanying and following attacks of influenza. And so he went to work. He was able to glean the data from the Army hospitals that you see there on the left, and then he was to compare and collect from 10 different sanitariums in the northeast of the United States, all Adventist, the treatment options there. And what he noticed was that early on is where it matters. Because once you develop pneumonia in a world without antibiotics, it's really, you really have a hard time. Notice that the mortality in both of these situations was about the same. In the Army hospitals, which had the best physicians and all of the best equipment, the mortality rate was 40%. Okay? In the sanitariums, with our Adventist-trained physicians doing the best that they could, it was about 55%. But remember, they were only talking about 11 people that got to that point. The reason why the sanitariums were so much better in terms of the overall infection fatality ratio, as you can see here, a sixth, was because they were able to prevent the patient from getting to the pneumonia phase. Only 2% of their patients went on to develop pneumonia, whereas in the Army camps, it was 16%. That was the major difference. And what did they do? Hydrotherapy. And what does hydrotherapy do? It increases the temperature, improves interferon. And where do we know interferon works? It's that first 7 days before you get pneumonia. For COVID, for flu, for all of those. All right, let's talk about diet. Really briefly, we've just talked about diet, and we're going to talk about diet on Sunday, but I found that this was a really interesting publication, Plant-Based Diets, Pescatarian Diets, and COVID-19 Severity of Population-Based Case Control Study in 6 countries. So during the COVID-19 problem, they grouped together healthcare providers in the UK, in France, in Germany, and the United States and Canada, and they had them on a network where they were able to compare, hey, what's working, what's not working. So they used this network of physicians, mainly male doctors, about 90%, and they did a survey. They wanted to find out how many of them had actually come down with COVID. And what type of COVID did they come down with? Mild, moderate, severe. And then they asked them also questionnaires. They said, what's the kind of diet that you eat? And they were able to break it down into a plant-based diet or a other type of diet, a high-protein, low-carbohydrate paleo diet. Now remember, these are physicians, so this is a fairly homogeneous population, what I think is really important, because a lot of the criticism of these types of studies is that if you're dealing with a person who is vegetarian, that means they're very health conscious and they're probably doing other things that are very health conscious, and that is probably explaining why they're getting better outcomes. Here we're talking about all of these people are physicians, they're all health conscious, and they're deciding to take these different diets because they are health conscious. Do you know physicians that have a paleo diet, high protein, low carb because they want to be healthy? That's what a lot of them do, right? Okay, so we're really able to look at one versus the other. And what did they find? They found that there was about 2,884 multinational study of healthcare workers, plant-based diet. It was associated with a 73% reduction in moderate COVID-19, a 59% reduction in severe COVID-19, and a low-carb, high-protein diet was associated with a 3.86 times risk of moderate to severe COVID-19. What about exercise? Exercise improves the viscosity of your blood. So you should probably already know where this is going. Well, physical inactivity is associated with a higher risk for severe COVID-19 outcomes in almost 50,000 patients. So listen to what they said. Patients with COVID-19 who were consistently inactive had a greater risk of hospitalization, admission to the ICU, and death due to COVID-19 than patients who were consistently meeting physical activity guidelines. Patients who were consistently inactive had a greater risk of hospitalization, admission to the ICU, and death due to COVID-19 than patients who were doing some sort of physical activity. And we'll show that you don't need to be doing a lot of physical activity. A lot of stress, a lot of mental abuse going on with the COVID-19 pandemic. Here's a great study. We're almost done here. So great study that looked at exercise. So Dr. Jennifer Heiss is in charge of the Fit Lab at McMaster University in Ontario, Canada, and she was working with a bunch of students, and it was getting down towards the last 6 weeks of the term. And for those of you who are a student, that's everybody in here because you're all students, you know that the last 6 weeks of the term can be very stressful. And so she wanted to find out what she could do about stress. So she divided this cohort. It was 61 university students for 6 weeks ending at exams. 72% of these students were female. 3 groups there were. There was one in the no exercise group, that was the control group. And then she had 2 exercise groups, but she wanted to break them up. She had a moderate continuous training group and a high intensity training group. And both of these groups exercised 3 times a week, Monday, Wednesday, Friday, but the degree to which they exercised was different. So one of them got up to about 84 watts. And what does that mean? That was about, well, the heart rate was about 142. So let's see how much that would be. Most of these are about 30, let's say 20 to 30-year-olds. And you know that 220 minus age will predict exactly what your maximum heart rate is. So 220 minus your age, that's going to be about 190, 180. So you can see here that we're well below the maximum heart rate, okay? As opposed to the high-intensity training, which got their heart rates up to about 174. So you can do the math to see what heart rate target it would be for you, just plugging in 220 minus your age, and that would give you what your target heart rate would be. So she wanted to know how things would go. So she measured something called the Beck Depression Scale 2, which is a highly validated depression score. She also took cytokine samples to see how much stress was going on in the body, and then they looked at other measures as well. Let's see what she found. And what you'll see here is it's called the hockey stick thing. And basically, the first thing that she noted here on the left is she looked at depression on the left, and notice that in the gray bar, those that did no exercise at all had a significant increase in the Beck Depression Inventory. So think about this. In just 6 weeks, that amount of stress led to that kind of depression. Imagine people going through a pandemic now in year 2. Actually, we're getting on to we are in year 3 now, okay? What kind of depression and anxiety that's going to cause. Those that did moderate amounts of exercise not only didn't get depressed, but actually there was a reversal in depression. So moderate amount of activity, just 3 times a week, was that effective at reducing depression. It's tremendous. They also saw it in the high exercise, but not to the same degree. What about anxiety? Again, the most effective was moderate exercise. You don't have to get off your couch and look like the people on TV in the gym. That's the point I want to make here. In fact, you don't want to do that because they actually have more stress than you do. You hear this, oh, he died of COVID-19, and he was a marathon runner. That's actually not ironic. Marathon runners have far more stress. Olympic athletes have far more stress than you would do just getting off and going outside and having light exercise 3 times a week. Same thing for perceived stress. The interesting thing is that those that did a lot of exercise had higher levels of perceived stress than those that did moderate. In fact, it was the opposite. Okay? So this is not something where you have to go out and break a sweat and work yourself up and be like the people that at 24-hour fitness that you see on the TV. To the contrary. What about tumor necrosis factor alpha and IL-6? These are cytokines, but they're bad cytokines. These are the ones that cause the issues in the lung. And so notice that in the moderate intensity group, they had much lower levels of tumor necrosis factor alpha and lower levels of IL-6. So what did she say? What did Jennifer Heiss say after this? She said, a critical question we sought to address was whether different physical exercise programs that prevent the development of these depressive symptoms also reduce pro-inflammatory cytokines. Indeed, we found support from this from 6 weeks of moderate intensity continuous exercise, which resulted in less depression and lower levels of tumor necrosis factor alpha compared to non-exercise control group. These results suggest that moderate intensity exercise may be working to reduce depression by decreasing tumor necrosis factor alpha. It's possible. Again, course of the disease, early treatment. It's got to be something that is very easily you don't need tests. It can be something that everyone can do. There's no hoarding of exercise, okay? There's no hoarding of hydrotherapy. You should be able to, let's think about a worst case scenario. You can get water, you can build a fire, you can get hot water, right? These are things that the government doesn't have to make. You don't have to have this produced. There's no trucks that have to deliver it. There's no pharmacy that has to make it, cut it, dispense it, give it to you. There's no money that you need to pay for it. These are the things that we ought to be looking at and know how to do beforehand, and hopefully, let's not make a time of trouble come on before it needs to, right? If we have medications and we have things that we can use it, but be prepared to be able to use things and have those things available in case that we can't use these things as well. And use it now in conjunction, right? There's nothing about any of this, what we've talked about, that cannot be used in conjunction with modern medical technology. Nothing. In fact, if we use this more, we might be utilizing modern medical technology less, because less people will be getting to the hospital, as we talked about. So is this revolutionary thinking? No, it's not revolutionary thinking at all. We've done this for a while. So key points: vitamin D and sunlight may impact our immunity to reduce morbidity from COVID-19, especially cytokine storm. Get your sunlight exposure. Natural substances like essential oils may impact our immunity in positive ways, especially in areas that are depressed by COVID-19. Sleep and its consequences have a major impact on our immunity, especially when it comes to viral infections. The most important part of sleep is at the beginning of the night before midnight. Does that sound familiar? Yeah, that's also associated with growth hormone, N3 sleep, all of that. Hydrotherapy, doing hot and cold. And we could talk a lot about what's going on in Finland with the data coming out with saunas, with the data coming out with hydrotherapy and things of that nature. It also impacts our immunity, especially with our innate immune system, which is crucial to fighting COVID-19 and basically viral infections in general. A plant-based diet is associated with significant reduction in severe COVID-19. Significant, okay? And exercise, and we'll talk more about that on Sunday. Exercise is also associated with a reduction in depression, hospitalization, admission to the ICU, and death. So where do you begin? Let's get practical. If you want to understand more about hydrotherapy and how to study that and look at it, and you don't have somebody that can teach you, or you want to be able to tell it to your patients, I would highly recommend these two websites that are at the bottom. Both of these websites are written by Seventh-day Adventists. The first one, Hydrotherapy at Home. I don't know if you know Rodney Bowes. Do you guys know Rodney Bowes? He's from Southern California, okay? Some of you guys know him. He helped, basically when I was doing the hydrotherapy talks on MedCram, I really wanted a landing space so that I could tell people who are interested out there to go to this place. Life and Health actually donated some of their videos so that you didn't have to pay for them to watch. And so those videos are hosted on that channel to show people how to do hydrotherapy. So I think that's a great resource. Hydrotherapy at Home, there's some videos on there. Hydroforcovid.com is also a great resource. It's authored by a physiotherapist living in Australia who actually practiced hydrotherapy and gave it to his patients. He has written that website in a way that a patient can very easily go to the website, see what phase of COVID they are in, and print out the protocol for that phase of COVID. And it's done in a very mindful way because there's actually a letter that they can print out to give to their doctor saying, hey, I'm doing hydrotherapy. If there's any issues, please let me know. I want to do this in conjunction with what you're doing. So if you want a place that you can safely send your patient knowing that they're not going to get some information that's just going to confuse them, I would highly recommend Hydro, the number 4, curecovid.com. You can go to it and actually check it out yourself. It may be helpful just to learn it. So if you're interested, that's where I would start. And with that, I think we're done.